Hi, I'm Kathy Kim. So you can see already from this panel, we've moved from self-tracking from the last panel to understanding what self-tracking in groups are and how science can help the self-trackers and how self-tracking in groups can help science to improve health for everybody. So even from the stories that we heard in the last panel about how people came to self-tracking, it was partly to help themselves, but it was also partly to help other people, to help others learn from their experience, and to help others from the quantitative skills that they had. I came to self-tracking as a researcher. I was starting a study on using self-tracking with youth who had obesity and were at risk for depression. And as I started the study, I realized I had never done any tracking on myself. And I had never tried to change my health in order to prevent some chronic illness in the future. But I actually had a reason I needed to do that. I had gestational diabetes when I was pregnant with my daughter. And my blood glucose levels and my HbA1cs every year were at that borderline. So I was pre-diabetic. And every year my doctor said, lose 5 or 10 pounds. Eat less, exercise more. And you can reduce your risk. And I, every year, said, of course I will. And then every year I didn't do it. And I said, I just need to lose this body weight. But how long do I get to use that excuse? Well, my son is 19 years old, so I figured I had 21 years till I had to actually do it. So my son's 19, and I said, okay, now here's an opportunity to try and understand what the participants we're going to recruit in our study might actually go through, because these are kids who don't think that they're sick. They don't go to the doctor for this condition. They know, oh, being overweight's not good, and sometime in the future I might get sick. But what does it really take to motivate them to make some change now when they don't feel bad? So I did start to do this self-tracking, and I said, okay, exercise, what am I going to do? Couch to 5K. I'd never run before. I'm going to start this program, and in 8 weeks I'm going to run a 5K. And I was religious about it, and I'm very competitive with myself, and I follow the rules, and I did everything, and 8 weeks later I was running a 5K. And then I went to the diabetes education class, and I tracked my food, and I tracked my calories, and I tracked my carbohydrates, and I followed it religiously. 8 weeks later, I had not lost a single pound. And I said, well, this stuff doesn't work. How can I do this study? This is terrible. And then I started reading about all the other things that people were doing to improve their health, not just around diabetes, but around other issues. And I started trying all these different strategies. And I found one that worked, and I'm not going to plug it because it's not going to work for everybody, right? But it worked for me. And 6 weeks after I started that program, I lost 15 pounds. And I can say now, just before my son's 20th birthday, I am down to pre-pregnancy weight. So I'm going to turn to the panel. And we have here an engineer, a psychologist, and a physician, and 3 scientists. So hopefully we can start to answer some of these questions about what can we learn from self-tracking in groups that improve science, and what can we learn from science that helps self-trackers. And I know as we were preparing for this panel that we talked about how much we were learning just from listening to each other's perspectives. And so I wanted to start with the panel and say, what have you learned today from hearing each other, and do you have questions for each other?
When you think about qualifying an instrument or a measure, it's something I still struggle with in my own work, what are some of the characteristics of a good measure, and is it context dependent?
Yes, that's easy. It is context dependent. So, and I'm not a scale person. There are people who specialize in scales, but generally what happens is you want a question or a instrument that is reproducible. So if you feel the same way, later on you would actually get the same number, right? So it's reproducible over time. You want it also to track changes, so if there are real changes, that it will show up on your instrument. And sometimes it's very hard to tell because there's inherent variability in how you feel, then there's the error of the instrument itself. And so you want to tease those apart. And the best instrument is one that's very precise, always gets exactly how you feel, and tracks that very clearly over time. That's very hard to do. That's just within one person, okay? It becomes much harder when it's a self-report, because maybe if you ask me, did I sleep well? I have a particular scale about what it means for me to sleep well, right? So asking me a question a certain way may not work for you. your response to that question may actually be very different. And then so I need to calibrate the way I use the scale versus the way you use the scale. But then the performance characteristics might be different for you than it is for me. And then when I start to aggregate that, then we start getting all kinds of noise, and the noises just kind of add up together, and it can really drown things out. So that's the challenge of scales, and it's something that clearly people have struggled with for a long time. That's what the PROMISE effort is at NIH, to test these instruments over and over again on lots and lots of people. So for low socioeconomic status people with poor health literacy, this is a good scale to use. In this context, for people who are really sick, this is a good scale to use. Maybe looking at the same symptom even. Another way is to ask ask different questions looking at the same underlying thing. So if you're asking for sleep, you might ask 3 different questions that get at sleep in different ways. So there are multiple strategies to do it. The other strategy is just to forget about asking. And I think that's where a lot of the power of mobile health is to measure passively something that might, in the old days, we would have had you come in every month and fill out a paper form. Now we can just measure something. And of course, that has its own problems with reproducibility and accuracy, but those are some of the ways around it. So there's a lot of science there that we need to work out.
I think one of the things that Ian taught me is about thinking about ways of aggregating. So if you think about this notion that we want to be able to learn from a group of self-trackers. We want to learn from replications of N of 1 experiments. How do you actually do that? And if you think about some of the varieties of clinical characteristics, it's a large variety, but it's not infinite. And if you think about a variety of treatments, it's a large variety, but it's not infinite. It's a very, very large problem space. But if you have enough people starting to populate that problem space, then you can do some Ian-type stuff. Magic. and essentially do what I like to, I tell people it's the Netflix thing, right? If I go online and, they've got my 5 top picks, and it's not, and then the other part that's really interesting is it's not the answer, but it's the beginning of the answer, and it gets you closer than the 5 to 7 or 7 to 10 years of experimenting that you have to do to get to that point. The translation also from the sort of inferential statistics and the clinical paradigm to the actual individual is I think, a very interesting and useful pivot.
So do you think there are different kinds of questions that you can answer with self-tracking groups that you can't answer with current sorts of methods?
Well, I think they are. Well, what do you mean by different methods?
Different methods of data collection or different scientific methods?
I think that, to me, it's very interesting to work in. I work in a medical setting, and for a long time, people sort of felt like they had to explain why we weren't. We had to explain why we weren't doing a randomized control trial, right? Because that's the sort of the gold standard paradigm for the clinical research scientific paradigm, and it's a great tool for understanding for isolating causality in groups of people. And if you want to know whether or not your intervention actually was the causal agent, and there's high utilities or the cost of making a wrong decision on either side of that, you want to do a randomized control trial. And, but often that's not the question you're asking. The question you're asking is not, does this agent work for, or is this the agent that made a causal change? What you're asking is, will this agent work for me? And that's a different question. And so once we could start to explain to people why we weren't doing a randomized control trial in that way, we're asking a different question entirely. And then they kind of, they got it.
Hippocrates has this quote that I like, which is, he says, You learn a lot more when you understand the patient who has the disease rather than the disease that the patient has. Right? So context, I mean 3,000 years ago, right? Context is incredibly important. And it's something that I think is missing from the clinical encounter. One of the things we're learning with the MyIBD and the N of 1 work in the clinical context is that, one, I was shocked at how well people adhere to answering their SMSs every day. I was shocked how well I adhered because I'd never self-tracked before. You know, I have all these Excel spreadsheets that don't go beyond 3 lines. And so that was one. But the other shocker is that the doctors are coming back and saying, well, I'm having meaningful discussion instead of fact-finding missions in my clinical encounter. And so the availability of context and the ability to take the context, which I can't remember, into my doctor's office. And I'm pretty good about taking notes when I go in, but I don't have a good memory of over the last 3 months. Oh yeah, I had that 1 month where I felt horrible a whole month. Oh, I forgot.
Yeah, the cool thing about that too is that is the difference, you know, if you think about design between goals and tasks, right? You spend 15 minutes in the clinical encounter doing a history taking. That's not what people want to do there. Doctors don't want to go in and be history takers. And patients don't want to be history givers. So when you take that out of the equation and you have the history there, you can do what you wanted to do, which was actually like figure out what the story is and make a decision.
Yeah, I think part of it is that traditional clinical research has been focused on discovery, right? And I think discovery generally is thought of as, do things work in the world? Do they work on average for populations? And really in the clinical situation, the process of discovery is very different. It's a question of do things work for a particular patient in a particular context. And I think, you know, yes, I don't like to take history. In fact, now I don't even take history. I just type when I find my electronic record, which is even worse. But what we would rather have is to have conversations that are informed by data. And I think that's the promise of self-tracking, is that there's data which is useful, that is purposeful, and that is useful for particular clinical decisions that we might want to take as a patient and clinician together, or as a patient, you know, by herself in her own life. And those are very fluid sources of data and fluid context that we need to manage. And I think that's why it puts such a big onus on visualization tools to make those patterns more obvious to us. And it also makes it more important that we have methodology to tease out what the signals really are, because it's really, really easy to be misled. It's easy for us to be misled in traditional clinical research, where you do an observational study and you think, well, estrogen is really great for heart disease. Well, it turns out taking supplemental estrogen is not. And we found out only because we use more methodologically sound methods. So data is great, but data can give you the wrong answer, and data only makes sense in the context of really good stories. So we need to think about all of that together.
So then do you think, so in an N of 1 trial, there's a different kind of data that you're collecting and a different interpretation of that data for the individual, not necessarily generalizable to the group?
It's not necessarily generalized. There are a couple of other things. So N of 1 is just a particular method. There are other methods, you know, the interrupted time study that are methodologically have different trade-offs. The N of 1 study is really great for things that have quick on-off, right? If I take caffeine and I sleep and I don't sleep, you know, I can do that and I can test that over a couple of days, right? But if I have something like depression, then it takes me a lot longer, right? Because I need to take my antidepressant for a longer time. Well, there's some diseases that take a long time to manifest. You can't do an N of 1 study where each cycle is 2 years. Probably not that feasible, right? What if you have a disease where if it doesn't work, you die? Well, you're not around for the next cycle. That's not going to work either, right? How about if, so there's the number of these kinds of things that make N of 1 studies not the appropriate thing. And that's actually part of what's really important about self-experimentation, is to know when you can get away with what. When is it okay just to do a casual, you know, gee, see what happens? When is it okay to do an A and B? When is it appropriate to do an N of 1 by yourself? When should you do an N of 1 in collaboration with your physician? When should you be actually part of a much larger randomized trial? And on our side, as scientists, we should be willing to trade off rigor versus pragmatism, and versus what we're really trying to learn and for whom. And I think we're not as good about laying out that matrix and understanding what our trade-offs are. And I think we need to be much, much more explicit about that, and get that into the peer review process and in the funding. And then also, you know, what we're doing even in the non-science world. I know there are a lot of experiments going on, a lot of testing and evaluation going on in companies, in the for-profit space, because we all want to know what works. And so I think the methodology is actually really important.
So you talked a little bit, Michael, about getting this into the clinical process and getting the information from cell tracking into the clinical process. So how could clinicians benefit from aggregating information from N of 1 or individual self-experimentation to really help their entire group of patients?
Yeah, so I think of somebody, I can't remember who it was on the earlier panel, talked about physicians as a guide. And I think one of the things that is frustrating to people in the healthcare system is not having the answer. With a disease like Crohn's disease or ulcerative colitis, it's somewhat mysterious. There's not rapid onset, offset of symptoms. Many things, many different factors create an effect. And so you really want to be able to say, just do this and it'll help. In fact, I have this, I think that, physicians get into this, not into healthcare because they want to make people better, right? Which is really, really frustrating for them because they can't. It's only patients actually who can make themselves better, and physicians can help that. And so if you have a starting point, if you're able to say, not, oh, I saw this other kid this morning, and I have this memory of this one kid, and so now I'm going to start making treatment decisions based on my the one anecdote. But if you have a way of saying, let's look at what other people are doing and what's happening with them, and then we can start together with a little bit farther along the road. I think my intuition, my guess, and we're testing this out, is that it's going to be really, really satisfying and for physicians, and actually take them less time to get their panel, if you're thinking about it in terms of sort of a population of kids in their practice, healthier. So from a practical perspective, what that means is less sick visits, fewer sick visits, and more well visits, and a much less hectic day.
Another really interesting implication, I think Ann Wright mentioned this earlier, that one of the hardest things about having a disease about which not a lot is known is that you don't have much control. And the second big thing that often comes up is you try things to get control, and you go to your physician, well, there's no gold standard clinical data, so can't help you, like my doctor said. Mm-hmm. And what's wonderful about having this tool is that rather than prescribing something, there's some wonderful stories out there about giving sugar pills because it was better than nothing. And so often people will prescribe because you go to the doctor to get a pill. You don't, you get an answer. And doctors are sort of really motivated to give answers. So the idea of having self-tracking as a tool, as a script that you can give, is you can say, I don't know whether or not what you're doing is going to help, but let's find out together. Here's a tool that we're going to use. We're going to go through this together. You can teach me, and I will help you. Hmm. But that's not part of your training. So we need the quant coach or training programs or processes in the clinic that enable us to deliver these tools and then to learn from an individual patient. The probiotic question is extremely complicated biologically. There's thousands of bugs. Probiotics contain dozens. And patients are on antibiotics. Well, which bugs are responding to that antibiotic? And, most doctors are over their heads. Most of us are over our heads dealing with that kind of complexity. And so I think that's a place where we can aggregate a lot of the know-how of how to test the hypotheses in an effective fashion. And the other area where I think we're learning to aggregate effectively is when you look at the prevalence of success, just as the simplest measure. So an anecdote is just a story, right? But 1,000 anecdotes and 900 people did really well, that's a statistic that you can do something with, even if it's not definitive.
Great. Well, we have about 10 minutes left, so I want to open it up to the audience to take questions. So if you'll come up to the mics. Please.
Thank you for the panel. My name is Ilan Rubash. I'm from Carnegie Mellon. I'm going to be the nasty cynic and ask the panel a question. Excellent speeches, though. My concern is when I think about the panels earlier in the day, the power relationship that those panels espoused was one in which you're investing power into the individual human being. The individual is learning how to use tools, how to track their own condition over time. This panel, it seemed to me as I was listening, actually flips the power equation and is investing power in the hands of the clinician, the physician, and the scientist, the researcher. And it scares me, and it scares me for the following reason. What I like about something new, like self-tracking, is that it's an ecology that's being born right now and needs a great deal of experimentation. It's a Wild West, if you will. And that means, for instance, rather than standardizing instrumentation so that we can compare like quantities between different people, we want the most diversity we possibly can have so that people individually can create and evaluate to their own best abilities processes that work for them. It means instead of comparing people by aggregating and creating statistics that statisticians will be happy about and can publish papers about, instead you create community by having people individually be able to speak with each other, as was espoused in earlier panels. So to me, as somebody from the outside looking into the self-tracking community, that idea of people communicating with each other individually, holding their individualism and not being statistically aggregatable at all, that has much more excitement to me than the idea of empowering physicians and researchers to derive better statistics, especially if it means imposing constraints that cause the amount of ecological diversity to decrease when this is so new.
Yeah, so I definitely want to take that point on because I think it's actually not a cynical point. I think it's a really important point. And I think that in no way is this meant to exclude that kind of open community. And in fact, I would say, and I want that community to be really robust and vibrant, is I think we're going to find out all kinds of interesting things just from the crowd experimenting that those of us in our ivory tower maybe don't know. I think the whole point is if we want to learn something that is at a population level, then there are some things we need to think about. Standardization does become important. It's perfectly valid to say there's some questions we shouldn't standardize on, and standardizing too early is a squelch on innovation, is a squelch on creativity, and so that's not something we want to do. But I think it's understanding that both of them, both sides, the more rigorous side has its benefits, and then the much more open, very personal communication definitely has a tremendous amount of value as well. So that's actually why Open mHealth exists, because it's not something that is prescriptive in any way at all. It's just giving tools so that people can explore and where reasonable, where it's appropriate to standardize for people who do want to standardize. For those who don't, that's fine too. So I think we want to accommodate as many approaches as possible, and none is more important than the other one.
Yeah, I'd say that the whole philosophy of personal experiments is that is a tool for the crowd. Yeah. And I could care less if a doctor gets involved unless they can be constructive to the discourse. Part of what that platform is trying to create is peer review, which means your peers, the other self-trackers who are trying to make sense of their own lives and conditions. And standardization doesn't need to be standards committees and statisticians and instrumentarians. It can be my friend Joe, who measured it in a certain way and saw some good result, and okay, I want to use Joe's instrument. And so the idea is that instruments can propagate. All that stuff is authored. Now, that same philosophy, one of the reasons I work with Michael's group, is that they have the same philosophy, but it is collaborative. It's not power to the researcher. It's how can the researcher and the doctor give power to the patient, bring them in as an equal, so that we can have a reasonable discourse about a problem. So when a mother comes and says, I give my daughter probiotics and I'm certain that it works, we respect that position. And we say, let's learn more. How much does it work? Is the $100 a month that's coming out of your pocket because your insurance won't cover it, is that worth it to you? And let's understand that together. And I think that's very different than the power dynamic that the system has today. And I don't want to say anything more.
No, I'm glad you raised that question because, and I'm glad that you actually said what I was going to say. It comes, it's much better coming from somebody else. But essentially, what I want to do is I want a world where everybody can be a scientist. I want to create a system that makes it easier for everybody to gather the data that they need, and at this point in the current milieu, it's not important to arrive at standards. What it is important to do is make the tools available so that people can come up with answers to that are meaningful for themselves. And so part of what we're trying to do is create a system that devolves that capacity and those capabilities outward as broadly as possible. In the future, it may become useful to have standards, but again, it's not going to be It's not going to be standards that are dictated by experts. It's standards that are derived from the utility of the experience of everybody in the community. And the trick is to have the tools that enable that peer review within the community to actually take place.
In the back.
So I'm not on the panel, but it sounds like it's not an either-or question. It's a both-and. The way that the question was posed was either-or, and I'm afraid of giving people too much information, but I think it's a both-and. And I want to build on that question, because it seems to me like one of the real limiting factors is actually HIPAA. And how do we anonymize the data?
Yeah.
How do we create a standard unit of measure, but also protect records and identity and anonymity? That's part of my question because it didn't seem to be mentioned, and I'm hoping that mHealth is covering that. The other part of the question that I wanted to raise, in particular looking at Open mHealth and the standards they're putting forth, what about self-organizing? What if I want to filter the anonymous data? What if I have a friend who's measuring the same thing I'm measuring and I want to see my friend's results alongside mine? Is that part of what you're planning? And if it isn't, maybe it's something you can add in.
It's definitely something that we're thinking about. I think that's what we would like to see happen. There are lots of privacy challenges. Specifically in mHealth, the privacy challenges are really quite, they're quite large. So your mobility trace, for example, that's very personal data. And that's not something that you necessarily want to share or share in a way that's threatening to you, and that's context dependent. So the privacy architecture of mHealth broadly and of Open mHealth, we don't quite know how to deal with that yet, honestly. What I will say is that the old model of where you get data, it's identified, it stays in, like, let's say, one database, and then you go to that database and you ask a question of that data. Okay, that's sort of the more traditional approach. And there you have, you know who these people are because it's identified, and you're going there and you're getting that data and you're asking a question. Another approach is to just leave the data where it is and have your question go to the data where that data is. And when you go to that data, you don't need to know who that person is. Okay, you really don't care. It's just an N. And as you do this, because you're distributing your query, not aggregating your data in one place and putting the query in one place, you're sending out the query, not having the data come to you. That kind of inverts the whole process, and it makes the privacy management actually very different. So there actually is a lot of research on how to deal with privacy. I think the other things we want to think about is very fine-grained control of privacy. So maybe this stuff you can let other people use, but this stuff you really don't want other people to use. And how do we do that? How do we even talk about it? That's really very open. And it's open actually across all of computer science and not just in health. But I think it's particularly acute in health.
Right.
It's a big issue.
Let me ask just a quick question. I'm curious, how many people in the audience feel like you really know exactly what happens with all the data that you put on Facebook? Are you good at managing your privacy in this incredibly small, relatively simple, closed ecosystem? The answer is no.
Simple.
So it's a design challenge because you cannot possibly give people all of the freedom to decide what should and shouldn't happen with their data in a way that, on average, people will be able to execute. So I think this is a fundamental tension in this whole space. And we often get around it by saying, I don't care. The rare disease populations I work with say, I will give you all of my data, all of my clinical data, like 95% of people, if it can help reasonably. And I think that and we were just talking about this actually earlier, we had a wonderful debate about this, that if I give my data to my credit card company and I give my data to my doctor, and I know that data is going all over the place. You have no idea how many places your data sits and how much people know about you. So I think number one, we sort of ignore the fact that privacy is a sham. It's not possible. In fact, John Mulbank says a wonderful statement. He says, the more you make data impossible to identify, the less useful that data is. So there's the Heisenberg uncertainty principle operating here. If you want the data to be useful, you have to take personal risk that that data might have harm. And so maybe, and this is John's idea, my wife who's a lawyer says, God, that sounds hard. But the right thing is to say, maybe what are the consequences we're worried about? Am I worried about being embarrassed? I just went and exposed, I had a health condition to a large audience, which will be up on the web. So now everybody knows, but I don't really care. So, but what if it had massive effects on my performance at work? Would I not get a job? Would I not get insurance? Obama's helped out with that a little bit, but I think we need to have a much higher level discussion about the sort of what are the consequences we're concerned about, because I think HIPAA is a solution that's not really thinking about the true societal problem.
So regardless of HIPAA, I think the two use cases that I wanted to highlight were the same, where the doctor wants to know for a short period of time about specific named patients and follow those patients for some change of treatment, follow them closely for 2 weeks, 2 months, and then have those names or people cycle through. And then me and my friend, we want to know about each other, long-term, short-term, whatever it is. But both are valid, and both are going to fight with HIPAA regulation.
Yeah.
And I just am wondering if it's going into the code, if it's going into the standards.
We're running out of time, but I want to make one last comment about that, which is the regulations, whether they're HIPAA or the Common Rule for Research or privacy agreements for technology, assume a power differential, which we've been talking about turning that upside down. But the power differential is that I as a clinician or I as an institution are getting you to consent to share your data with me. It's not about people sharing with each other. So we don't have the regulatory or legal frameworks to deal with true democratization of data sharing. And I apologize because we are now out of time, but let's thank our panelists and thank you all.